Hello, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Today, we're honored to have a world-renowned leader, educator, and a clinician in the field of GI malignancy, Dr. Cathy Eng from Vanderbilt-Ingram Cancer Center. With Dr. Eng, we hope to discuss her approach to treating colon cancer and to reiterate the current standard of care treatment options. Dr. Eng, welcome.
Thank you so much for having me today. It's my pleasure to be here.
Thank you for joining us, Dr. Eng. We have divided this algorithm in different stages. To start, can you please review current algorithm treatment options for stage 1 and stage 2 colon cancer?
Great questions. And so stage 1 colon cancer, honestly, it is a rarity if we see it in medical oncology. The majority of patients tend to stay with the gastroenterologists and the surgeons just because there is no recommendation for any additional adjuvant chemotherapy in this setting. The outcome for these patients is extremely good, probably with a close to 90% plus 5-year survival. So I think I've maybe seen a handful of patients in 20 years. For stage 2 colon cancer, obviously that's when we start putting the patients potentially at slightly higher risk, especially if they have T4 disease or invasion of a nearby organ or perforation at presentation, but they're still lymph node negative. Historically, the data had not shown any traditional benefit for the role of adjuvant therapy. As many of you know, it has been explored what would be considered a high-risk setting, whether or not there's a suboptimal lymph node dissection, whether or not there was perforation. And now we've had some data regarding the role of circulating tumor DNA. And it brings to mind, obviously, that now we can start utilizing some newer technology and trying to identify the role of tumor shedding through analysis, not only of the tumor tissue, whether it's tumor-informed or tumor-agnostic, as well as a blood sample, obviously, to look for minimal residual disease. I just would like to kindly remind individuals the ASCO guidelines, the NCCN guidelines have historically said, please have this discussion with your patient whether or not you want to pursue any adjuvant chemotherapy, and always test for microsatellite instability regardless of stage. I think that's the most critical thing to keep in mind because that has a huge impact. So for our stage 2 patients, once again, traditionally adjuvant chemotherapy has not been recommended unless there's been that discussion with the physician and the patient the patient or the physician felt that they were at higher risk. We want to remind people there's an ongoing trial specifically in stage 2 colon cancer patients looking at the role of circulating tumor DNA, and that's the COBRA trial, which is enrolling nationally.
Yeah, and I cannot reiterate the importance of exploring clinical trial options for any stage of colon cancer, specifically now when we have evidence of circulating tumor DNA in stage 2, as well as now working with stage 3. Dr. Eng, for stage 2, as you pointed out, post-ASCO 2022, where we actually saw a dynamic study and the role of circulating tumor DNA, which was presented, this has given us more sophisticated tool in selecting who should perhaps be considered for adjuvant chemotherapy. Dr. Eng, in your practice, post-adjuvant treatment, do you repeat circulating tumor DNA outside the clinical trial settings for these patients, or you follow them with surveillance scans?
Once again, stage 2 it's a smaller number of patients that we commonly see in practice, but I have been following them with a circulating tumor DNA for some patients that are concerned about their risk of recurrence. I think that's a fair approach. And so off protocol, I'll follow them with standard surveillance scans once a year, standard, physical examination, CEA, etc. But I have ordered a circulating tumor DNA off protocol in select settings where I couldn't get the patient on the trial.
Okay.
Thank you, Dr. Eng, for sharing that. And in the same population, again, for stage 2, rare or a small population that gets chemotherapy, but if you are given chemotherapy, do you tend to lean towards 3 months of KPOX as per IDEA trial or 6 months of FOLFOX?
Great question. So if I were to provide adjuvant chemotherapy, oxaliplatin-based in the stage 2 setting, my tendency would be to provide 3 months of adjuvant chemotherapy. But let's say I had a T4 tumor patient that perforated and had a suboptimal lymph node dissection due to the emergent situation where they were taken to surgery. And we didn't have a baseline CEA because they did not know, obviously, that that patient had colon cancer per se. I would not disapprove continuing on the 5FU portion past the 3-month duration if I really felt that patient was at high risk of recurrence. And I think, we've all seen once in a blue moon that T4 patient that had, a perforation and had a serious infection afterwards and had the delay and they're at high risk of recurrence. I would not be opposed to continuing on the 5FU based portion or Xeloda if you're going to do CAPOX. I think once again, that's really a discussion with the patient. I do not continue the oxaliplatin beyond 4 months because of the high risk of cumulative peripheral neuropathy, because these are patients that are supposed to be NED and it's a quality of life issue.
Absolutely. Thank you for addressing that. Moving right along, we've touched briefly on IDEA trial. Dr. Eng, can you please walk us through your approach for stage 3 colon cancer?
Yeah, stage 3 colon cancer obviously means our patient has lymph node positive disease. And for an MSI stable patient, our standard of care is adjuvant chemotherapy. Although the data from IDEA indicates that obviously CAPOX for 3 months is an excellent approach. And for those select patients that want to do full FOLFOX, there's a slight difference in regards to 5-year overall survival. But once again, I do not like to continue the oxaliplatin beyond the 4-month duration. In this setting, these are patients that just need to be followed very closely. You want to make sure they've had optimal lymph node dissection. Obviously, if a patient had 3 lymph nodes out of 4 that were positive, that's not necessarily favorable, and that patient would be considered high risk of recurrence because of the suboptimal lymph node dissection. But stage 3 is just a area where we need to follow these patients closely. Once again, depending upon how they presented and depending upon the surgical approach. And whether or not they were able to tolerate their adjuvant chemotherapy. Keep in mind, when you're in real life practice, on these clinical trials, these patients have great performance status, right? Yeah. They're perfect patients, right? They all have an ECOG PS of 0 to 1. They don't have any issues getting insurance coverage, everything's perfectly timed. But the reality is that when you are actually treating these patients, I don't know about you guys, but despite my dose reduction, right, with the CAPOX regimen and reducing the oxalate from 130 to 100, my patients, there are still some patients that just don't tolerate CAPOX well. I've had patients with pretty significant diarrhea or they're just not good with pills and they end up with nausea and vomiting. And, in that case, I have no problem transitioning them. CAPOX is convenient. It's great if you are able to tolerate it. But there are those patients that sometimes they're just not good with taking multiple pills, and sometimes they are better off with quality of life with the FOLFOX regimen, or just, as I stated, if it's past 4 months, just continuing the IV pump 5FU. So I always want to make sure that you have good communication with the patients, whether it's with you or whether it's with your APP. It's extremely important because I think we all know once those patients get dehydrated with that diarrhea, they end up hospitalized. So we have to be careful. And for stage 3 setting, there is a circulating tumor DNA study called Circulate US, which is also just opened last fall and is currently open nationwide, looking at the role of circulating tumor DNA and whether or not you should receive standard oxaliplatin-based therapy or whether or not you're at high risk and may benefit from FOLFOXIRI in the adjuvant setting. So that's the new aspect of this trial.
We eagerly await for some of these clinical trials to result out because, again, the quality of life, especially when we know that these patients might already be cured, might not need treatment at this time. So now, just addressing this quality of life issue as well, now in metastatic disease, we often omit 5FU bolus in palliative settings. And there was a recent retrospective study from GI ASCO 2023 to support this practice. In adjuvant settings specifically, how comfortable do you feel omitting 5FU bolus here? And should we extrapolate that data for adjuvant treatment option?
And so the reality is during the era of COVID, which is still present, you have to obviously watch the patient's immune system and watch their white blood cell counts. And so I have traditionally omitted it in the adjuvant setting as well as in the metastatic setting. I do not personally think it compromises the patient's care. And the reality is that a lot of patients end up omitting it anyways because of the myelosuppression.
And like you pointed out, a lot of us were doing that in metastatic settings. At least my current practice was to give it in adjuvant settings and taking it away in metastatic settings. So thank you for bringing that up. Now, I think we can jump right into metastatic disease treatment options. Dr. Eng, how do you decide what patient gets the right first-line treatment here?
Oh, well, first of all, as I mentioned earlier, MSI testing is critical in the treatment disposition planning of patients, just because we know there is a role for immune checkpoint inhibition in newly diagnosed MSI high patients, potential role. Obviously, it's not for all patients. And there's some very intriguing data, obviously, for combination immunotherapy, but also NGS testing or next generation sequencing is so important for our patient population, especially those that are diagnosed with a BRAF V600E mutation. Nowadays, even HER2 new testing is extremely important, although once again, BRAF, MSI stable is less than 10% of our patients. HER2 is less than 5% of our patient population. And then obviously for our newly diagnosed MSI stable patients, sidedness also has an impact, and RAS status, whether it's KRAS or NRAS, just any RAS, testing is important for our patients. So a large bit of my approach is dependent upon what the molecular analysis shows, and if we have a clinical trial available, and if not, obviously we'll treat them off protocol. Now, if I were to have to choose between, FOLFOX or FOLFIRI, because people always ask me that question, or do I choose FOLFOX-IRI? I have that discussion with the patient, and I really ask them what side effects are they willing to consider, especially if they're in the setting of surgically unresectable disease. It's different if you're providing shorter course or defined course for the neoadjuvant setting, and then you're thinking about doing hepatic resection or lung resection. But for patients with surgically unresectable disease, there's no difference between FOLFOX and FOLFIRI, other than the toxicities. And then obviously with FOLFIRI, there's no issues with neuropathy or the cold sensitivity. I do like FOLFOX-IRI in some of our younger patients at times, and especially if I'm trying to shrink some of the tumor burden, whether it's due to preparation for liver resection, sometimes I do take that into account.
Thank you. You, Dr. Eng, mentioned the importance of sidedness and RAS wild type or the pan-RAS. We've seen approval for HER2 amplified tucatinib and trastuzumab to a small population. A patient with left-sided RAS wild type HER2 amplified, would you still consider anti-EGFR in first line, or would you consider moving your anti-HER2 agents up front?
Yeah, it's a great question. So if you have one small proportion of patients, but if you were HER2 amplified, if you are RAS wild type, there is the Mountaineer 3 trial that I would encourage people to participate in. It should just be opening up across the country, which is for newly diagnosed metastatic patients, where you can add tucatinib and Herceptin in combination with chemotherapy in this phase 3 trial. So in that setting, but I think what you're referring to is, would you want to consider if the patient's HER2, are you concerned about resistance to EGFR therapy? And there is data that suggests that if you're HER2 positive, you are less likely to respond to anti-EGFR therapy. That is very intriguing data. It is compelling. Have I ever given a patient treatment with EGFR therapy, even though they were HER2? I have done it once. I would have to say it's an anecdotal finding, and that's because, you have to explore other options when the patient doesn't have a clinical trial available. But I think that is very important. Thank you for reminding me, because we want people to not only test for HER2, but also make sure that you think about that when you're considering anti-EGFR therapy.
Thank you.
Thanks for addressing that. Dr. Eng, in a patient progressing on our first-line treatment options, so we have few second and third-line treatment options available. How do you decide on those? And when talking about regorafenib and TAS-102, how do you usually dose these patients?
Yeah, so in the refractory setting, following FOLFOX or following oxaliplatin or irinotecan-based therapy, as you stated, we just have a handful of therapies. I mean, obviously, if the patient is RAS wild type, we're going to consider anti-EGFR therapy, presuming they're not HER2 positive.
Right.
But in regards to TAS-102, we've had the data that was positive from the Sunlight trial. I would say it wasn't groundbreaking for us in the United States. I think many of us were already utilizing TAS-102 plus bevacizumab. The issue with TAS-102 on the FDA insert scheduled dose of 2 weeks on, 2 weeks off results in increased myelosuppression. So I've been doing my own approach for probably a good I've been here how long? Probably a good 6 years now or so, where I've been alternating Monday through Friday, alternating weeks. And that actually works out well with the bevacizumab. And we actually reported our retrospective analysis at ASCO and ASCO GI with an update. And we have a publication pending. So that's the main issue with TAS-102, though, is myelosuppression. That's not to say that patients may still not have some myelosuppression with the alternating week dose. Yes, we do see some, but it's not to the same degree. Because some patients will be so significant on the 2 weeks on, 2 weeks off that they have to get Neulasta, and that's not ideal for some patients, given that it's an oral agent. And bevacizumab is still IV, to keep that in mind. Regorafenib, obviously, we can provide a lower dose, and I do prefer to provide a lower dose when I utilize it. The issues are the standard dosing of 160 is the significant hand-foot skin reaction that can happen with the callus formation, fatigue, and the risk of increased LFTs. And that's an issue for a patient with multiple liver metastasis. However, I do believe that you can redose, and I have started patients at 80 and gone up to 120 when I utilize that.
Perfect. Dr. Eng, as we're discussing later lines here, for quintanab, it's a drug already approved in China, and the global data from FRESCO-2 looks very promising. Can you please share a few key points for this trial, its design, and its filing as we await for its approval?
Thank you so much for asking. Yes, so this is a selective oral inhibitor, specifically VEGF receptors 1, 2, and 3. And there is no associated cytotoxic therapy. It is an oral agent, and it's provided 3 weeks on and 1 week off. This drug was provided to patients. They were allowed to receive prior Lonsurf or regorafenib, or have been exposed to both. This was an international trial with investigators involving Australia, Japan, Europe, and the United States, and enrolled very quickly within 16 months. And our primary endpoint was overall survival, and we fulfilled the primary endpoint for overall survival. Now, in comparison to a placebo as the control arm, because in all fairness, and as mentioned earlier, the current drugs that are available in this setting are only Lonsurf and regorafenib. So there is nothing past that in regards to a control arm. And we had a very nice improvement in hazard ratio with 0.66, an improvement overall survival of 2.6 months, and an improvement in PFS of 1.9 months. The median lines of therapy for people that participated in this trial was 5 lines of therapy. So this was heavily pretreated patients and significant benefit in regards to overall survival and PFS. But if you even look at those patients that had received it in the third line setting, and you look at our forest plot, it also is conclusive for benefit overall. So this is currently sitting at the FDA undergoing review. The primary side effects, as you can guess, for this class of agents, because it is an anti-VEGF agent, is hypertension, very similar to bevacizumab, and less than 10% risk of hand-foot syndrome and asthenia. So,
well, congratulations on these excellent findings, Dr. Eng. Once in practice, we learned stepping up dosing of regorafenib was a better approach. Do you envision we will start slowly and then up-titrate for quintanab as well?
I don't think so. I mean, we saw, prolonged benefit of stability for patients, for the majority of patients. And I don't know if we really need to, increase the dosing to maximize it any further. I feel very confident that if you move it to an earlier setting, not necessarily the fifth line setting,
Right.
you're probably going to see a significant benefit for the patient. And as mentioned earlier, it's tolerated well. We don't have any issues with myelosuppression or hand-foot skin reaction. I look forward to seeing some additional data in combination. We just finished our phase 2 data in combination with immune checkpoint inhibition, and I'd love to see the overall results. It was a small multi-site study that was just completed just last month. So
That's incredible. To summarize, exploring clinical trial as an option for any stage is extremely important. Role of circulating tumor DNA continues to evolve, and this will help us in selecting the right patient population for the right treatment. In metastatic settings, we have recently seen approval for HER2 amplified patient population through Mountaineer study. We will eagerly await on approval for fruquintinib. Dr. Eng, thank you so much for being with us today and reiterating the current standard of care for colon cancer patient population.
thanks so much for having me here today. I really appreciate it.